A survey of the outcomes and predictors of mortality in H1N1 patients in the ICU during Hajj in the year 2009. Once again, this study was conducted by the Saudi Critical Care Society and the Society of Hajj and Medicine. First of all, I want to start with a retrospective view of H1N1. As my colleague stated before, that the first outbreak of H1N1 was in 1918 that claimed the lives of over 40 million people, mostly in Spain. That's why they called it the Spanish flu. Then there was another outbreak that basically led to the development of the first H1N1 vaccine in the 70s, and the vaccine was given to over 45 million Americans. This is the CDC graphs about the death that basically happened of H1N1 in 1918. Of course, the first outbreak claimed the lives of young people, while the second one claimed the lives of old people. And this is basically a graph that represents the seasonal flu versus the H1N1 pandemic. As you can see, the severity in the H1N1 pandemics is greater in clinical symptoms, hospitalization, and death compared to the seasonal flu. This basically graph shows the mask dilemma and abusage. I would like to say something here that I've seen personally in Hajj. One of the merchants there were actually selling these masks for 5 riyals per mask, and they were lying to the pilgrims and telling them that these masks provide sufficient protection from the H1N1 for the duration of Hajj, around 5 days. As for patients at risk, the high-risk patients, well, this is important because you're going to ask yourself, are you going to initiate antiviral medication or not for this patient? High-risk patients are basically extremes of age, pregnancy, immunosuppression, and chronic conditions. Of course, this graph shows some sort of behaviors that will basically associate with the risk of acquiring the infection. As you can see, some sort of social greetings carry a very high risk of carrying the infection transmission. And this picture here elaborates my point. See how crowded this area is. The World WHO recommended diagnostic laboratory tests are many, but the one we used in this study is actually the PCR, which takes 1 to 2 days for the results to come back. And actually, I've seen it happen in 9 hours or less during Hajj. Of course, viral culture is the golden standard, but it was not used in Hajj due to the time factor. As for the management modalities provided for these patients, mainly were isolated. A lot of these patients were isolated, viral filters, of course, antiviral medication, antibiotics, sedation, rehydration, and basically appropriate ventilation. The use of steroids was basically contraindicated here. However, some patients did receive steroids. As for the initiation and times of antiviral medication, you're going to have to basically review the risk factors, and this is basically a subjective decision depending on the physician. If the patient is high risk, then he should be given antiviral medication, ostomavir or zenamivir, basically the drugs. And some patients were actually given a double dose of Tamiflu, of course, which is 150 milligrams, and double the duration. If the patient is low risk and the severity of symptoms are not that great, then you should not be started with antiviral medication. Of course, whether the question to start zenamivir versus ostomavir basically depends on the presence of resistance and the scarcity of ostomavir, is it present or not. I've seen some physicians who actually use both drugs on the same patient. It depends once again on the severity and the risk group. As for preventive precautions, basically avoid contact, face masks, and personal hygiene and vaccination. As for the vaccination candidates, they're basically pregnant women, household contacts, healthcare personnel, and anyone under 24 years of age. Above 24 or 25, basically depends on the risk factor. As for the study itself, the study basically was a prospective study done on basically 38 patients performed in 10 intensive cares in Mecca and the sacred places for 2 weeks, as the patients were followed up for 5 days. The data sheet here was actually formed by a Canadian group forming an international survey for H1N1, and the entire world was sent here basically survey patients during Hajj. As for the outcome, basically for primary and secondary outcome, the primary outcome was determined on the ICU mortality rate and the predicted mortality rate. As for the secondary outcome, was basically done on the frequency of ventilation, the duration of ventilation, and the ICU length of stay. This is part of the sheet you see here. It's basically they emphasized on the eligibility criteria, which we'll come to that, because they wanted to do the study mainly on H1N1 patients, not on pneumonia and seasonal flu patients. It did go into medication with great details, as you can see here, and a lot of other vitals and respiratory information. As for the patient eligibility criteria, 3 categories come into mind: the clinical categories and the epidemiological criteria, as well as the laboratory criteria. The clinical criteria is basically the symptoms, and they're mostly coryza symptoms, as in fever, rhinorrhea, cough. We'll come to the percentages of these symptoms. As the epidemiological criteria, travel, as in all of the international pilgrims, and close contact. The laboratory criteria mainly consist of the PCR results. study, he had to pass one of these eligibility criteria, otherwise we would not fill a form for him. 40% of the patients were confirmed by PCR, 31% were admitted through ICU as query H1N1, 18% received mechanical ventilation for respiratory illnesses, and 8% were chronically ill due to respiratory illnesses. As basically the ethnicity, 37% were South Asian and 13% were Asian. By Asian here I mean Pakistani and Indian, and 16% were African and 34% were Arab. By Arab I mean Egyptian, Syrian, Jordanian, and so on. The gender, 56% were males and 44% were females. The median age, 51 was an extreme of 80 and a minimum of 20. And 10% of the patients who were H1N1 positive were actually vaccinated for H1N1. The patient's presentation, 75% of patients presented with flu-like illnesses, but with severe presentations. 6% presented with CNS symptoms, as in headache and seizures, and 30% presented with GI and a combination of flu-like symptoms such as nausea, vomiting, abdominal pain, and diarrhea. This is the constellation of symptoms. As you can see, cough was the most common symptom presented in basically 31 patients. Fever was in about 27 patients, and myalgias also came in about 17 patients. Purulent sputum was also present in about 17 patients. As for the comorbidities of the H1N1 patients prior to their diagnosis, the majority here basically was hypertensive, diabetic, also obesity played an important role in asthma. Of course, there were some patients who had cancer, and the smokers were actually here basically about 7% of the patients were smokers. As for the H1N1 complications encountered in this survey, 17% suffered from exacerbations of chronic diseases, mainly COPD, 8% suffered from upper respiratory tract infections, 35% developed status asthmaticus and pneumonia, 21% developed secondary bacterial pneumonia, and 5% came with rhabdomyolysis. Those patients mainly came with trauma too. As for the survey of pregnant women in Hajj who had H1N1, I remember 2 patients who had H1N1 and were pregnant. One of them were actually in the beginning of the 3rd trimester, 20 weeks, and the other one was in 30 weeks of gestation. As for the one that was in 31 weeks of gestation, she actually, they did a CTG for her, and they discovered it was non-reassuring CTG, and the consultant actually decided to induce labor and save the baby from hypoxia. Both the mother and the baby had a very good outcome, but I don't remember the AlI score for them. As for the FDA, approved the osmavir and zanamivir as pregnancy category B drugs, and therefore their benefit outweighs the risk, and they can be given in pregnancy. This is basically antibiotics were given to H1N1 patients. Almost all the patients received a single course of antibiotics. 80% received 2 antibiotics, and 6% received 3 antibiotics consecutively. And these are the antibiotics, as you can see, some of them very powerful, like vancomycin and stuff. As for the Tamiflu doses, 62% of the patients in this study received the double dose of Tamiflu, and 32% received the single dose, 6% did not receive the antibiotic medication. This is again a subjective decision due to the physician. As for the overall ICU mortality rate was 5.9% for the H1N1 patients, with the major causes of death being multi-organ dysfunction, malignancy, and septic shock. The average length of ICU admission was 8.5 days. As for the H1N1 patient ventilation methods, 65% of patients received invasive ventilation, while 15% non-invasive ventilation, and about 19% received no ventilation. The average duration of ventilation was about 6.45 days. And this is basically regarding the adjuvants and mechanical ventilation. 19% of the patients received high-frequency ventilation, and 5% received nitrous oxide, and 14% received rotoprone ventilation. So in summary, swine flu was a prominent threat to the intensivists during Hajj. The average length of stay was 8.5 days, with a mortality rate of 5.9. The H1N1 can manifest with a wide variety of the spectrum of symptoms and signs, and not only the classical flu-like illnesses. Early recognition and initiation of antiviral medication in high-risk individuals will improve the overall outcome of ICU patients with H1N1. So in conclusion, through both preventive precautions and basic health care, we can significantly decrease the ICU length of stay and mortality rate for any epidemic.